Thank you for joining today. My name is Kerri Cornejo, and I'm the Policy Coordinator in the Federal Office of Rural Health Policy within the Health Resources and Services Administration. The purpose of my presentation today is to give you a short overview of the issues related to funding telementoring programs. In short, the main issue is that telementoring programs need both upfront and ongoing sources of funding. I'm going to delve into the issue by first providing a look at what we know about how telementoring programs are funded currently. Then what opportunities exist or what strategies might emerge to support sustainable telementoring programs looking longer term. As you can see here by the definition of telementoring, it's a way to deliver training, education, and support outside of the in-person, face-to-face setting and expand the capacity of the rural health workforce. A recent report from the U.S. Department of Health and Human Services identified funding and financial sustainability as challenges to maintaining telementoring programs. This is especially important considering various program activities that may be outside of the realm of typical billable services. And while grants have been key funding mechanisms for telementoring, they may not be the right strategy for long-term sustainability. And a big issue there is that grant funding is often time limited. So telementoring programs funded through grants may need to consider other avenues of financing to ensure continued access to their services. As you can see here, federal support, particularly through grants, is a major funding source for telementoring programs. In the HHS report I just mentioned, 32% of funding for the telementoring programs studied were grants from my agency, HRSA. However, telementoring programs are also funded through a number of other mechanisms. For instance, some states have used funds through their Medicaid programs to support Project ECHO activities, including New Mexico, Oregon, California, and Colorado. A brief from the Center for Healthcare Strategies noted state Medicaid programs and their delivery system partners leveraging strategies such as 1115 waivers and accountable care to fund telementoring. And circling back to the HHS report, it also documented some activities of telementoring models to sustain their programs, including establishing fees, subscription models, and other mechanisms to offer paid services. I'd also note the establishment of codes for things like interprofessional consultations and chronic care management, and their adoption in Medicare in recent years. And while I'm not an authority on billing and don't mean to suggest anything about using these codes for telementoring specifically, they do reflect a recognition at the federal level of the benefits of funding information sharing activities that aren't directly patient-facing. So taking everything we know about how telementoring programs are currently funded and the gaps and opportunities there, what are some of the strategies to sustain telementoring programs longer term? First on the list here is diversifying funding sources for telementoring. Grants are wonderful opportunities to get upfront funding and support activities that others might not pay for, but they don't usually last forever or cover all the funds you might need to support a growing program. And a related question is, what is the ideal balance of funding sources and how might this change over time? Value-based care models, like accountable care organizations and others, may be promising strategies to support telementoring. They have a focus on innovative payment models that can often fund activities that improve health outcomes, but aren't traditional billable services. And lastly, the HHS report I discussed talked about the importance of balancing the enthusiasm for telementoring programs with the need to gather evidence on their effectiveness. And taking this point a step further, looking at the long-term future of telementoring, on the federal side at least, it's so valuable for us to have this evidence base to support our programs and policies. And out in the field, a strong evidence base could help build the case to further incorporate proven telementoring activities within our healthcare system.
Good afternoon, and thank you for joining me. I'm going to talk to you today about telemedicine, telehealth, and telementoring. These items have been extremely helpful in helping us address the recent COVID-19 pandemic, but there is a lot of confusion about where we go from here in these areas. The first thing I want to touch on for you is telemedicine and telehealth. Now, obviously, as you all know, there's a big division between federal and state policy. Your state policies are going to be the ones that really address what is permissible in your state related to the standard of care in telemedicine and telehealth. The good news is that generally these policies really focus on the standard of care, i.e., as long as the standard of care is being met, most of the states are fairly permissive, but you are going to want to check your own state's policy in relation to how video is required and how and when things like store and forward of a static image, like an X-ray, are allowed. And that's the underlying basis of what's permissible under the law in the states. Federally, those laws really address the items surrounding the practice of medicine, and we'll get to those at the end. The second pieces, obviously, that you're dealing with are going to be reimbursement. Now, the federal and the state public health emergencies have different timelines. Most all of the state PHEs are gone. There are some left, including Texas, but the federal PHE is still in place. It is set to expire this week, but almost everyone expects an extension because CMS has made it very clear that there will be a time frame in which they give us a warning before the official end of the public health emergency. Now, why is that relevant? It's relevant because the public health emergency is what is allowing billing to occur through CMS-backed services like Medicare for telehealth and telemedicine outside of very narrow geographic requirements. And there are lots of bills right now that are live in Congress that are looking to address these reimbursements. However, the vast majority of them sort of kick the can down the road and give us an extension to allow those reimbursements to continue to happen for another year, maybe another 2 years, while we gather information before they make permanent changes. But the good news is it looks like we'll have the space to do that. Now, telementoring is a different story altogether. A handful of states do allow for direct reimbursement, i.e., you submit a bill and you get paid for it, but not very many. There are pilot projects everywhere on this. There are all types of inventive ways that people are trying to look at figuring out a way to cover this benefit because they recognize how meaningful and how beneficial it can be. But I do want to point out that there are what we would call reimbursement benefits beyond that sort of simple direct billing for a service model. And that is when a patient is able to stay in their home location and continue to have that good care relationship with their physician. The other items surrounding that are the ones that become billable, and it increases the patient care. It's better for the relationship between the provider, and it allows it to be sort of almost subsidized by the other billing that surrounds the care given in that relationship. So keep an eye out for that possibility. Then finally, I want to touch very quickly on those other federal considerations. These relate to HIPAA and the privacy laws, Stark and anti-kickback laws, prescribing laws, and licensing laws. These were all given pause under the public health emergency, but when that ends, these will end. So if you haven't started preparing, now would be the time to do so. Thank you so much.
Greetings, everyone, and thank you for joining as I talk just a few minutes on current challenges and opportunities in the rural primary care workforce. Healthcare workforce shortages have been a long documented challenge for rural communities, with current estimates anticipating even greater challenges following the COVID-19 pandemic. We're facing tremendous workforce gaps, but exactly how big and whether that's anything different for our rural communities still remains to be seen. To adapt to their workforce shortages, rural facilities are already more likely to be staffed in collaboration between physicians and advanced practice providers like PAs and nurse practitioners. For example, board-certified family physicians in rural areas are nearly twice as likely to work with advanced practice providers. This is important because we know that team-based care, with the patient being co-managed by physicians and advanced practice providers, is associated with better outcomes for management of multiple chronic conditions. But what happens when that team-based approach isn't an option? What happens when our primary care safety net operates in a highly rural or remote region, or they just don't have access to the kinds of specialist support that they need? With all of this in mind, we should be thinking strategically about what we know works for rural recruitment and retention to allocate the right resources. So what is it that we do know? Research tells us that nurse practitioners are more likely to practice in rural areas, and that physicians are most likely to practice within 60 miles of wherever they conduct their residency program. We also know that if a provider is retained to at least 6 years, they're more likely to remain in the community long term. But we also must recognize that most loan repayment programs are done in 2-year increments. And maybe most importantly to our conversation today, rural and remote physicians that have access to mentorship and networking are more likely to report a positive rural experience. So how do we help rural primary care providers feel supported so that they want to remain in a rural practice? So let's look again at what we know, that rural family physicians had adopted telehealth at a higher rate than urban prior to the pandemic. And during the pandemic, we saw an explosion in the use of telehealth in both rural and urban settings. So now that many facilities have enhanced their systems to support telehealth, it's also a time to consider leveraging that system for other uses. Ultimately, we are here today to talk about the benefits of telementoring, and I want you to think about it as a recruitment and retention tool as well. With an established telementoring hub in each state, we can offer an effective mentoring resource to the rural primary care workforce. And statewide partners can leverage existing Project ECHO models to provide meaningful telementoring networks to rural practices. So I'd encourage you to explore the free resources and technical assistance offered by the Rural Telementoring Training Center, and at least one partner in each state reach out and learn more. And one last thing before I let you go, I want to invite you to join the National Organization of State Offices of Rural Health and the Rural Telementoring Training Center in celebrating the positive attributes of rural America on National Rural Health Day, this year on November 17th. For more information, visit powerofrural.org and be sure to use the social media hashtag #PowerOfRural. I thank you for your time today, and I appreciate the opportunity to spend just a few minutes with you.
Thank you. So as was mentioned, I work with NTCA, the Rural Broadband Association. We represent about 850 fiber broadband providers, all of whom are locally operated throughout rural areas of the United States. These companies typically have about 6,500 customer accounts, and their service areas have a population density of between 7 and 9 people per square mile. So those same rural conditions that affect the ability to provide broadband to those spaces also affects the ability to find access to adequate healthcare in those spaces as well. Rural areas have higher incidences of chronic and acute medical conditions, including heart disease, cancer, unintentional injury, diabetes, COPD, than counterparts in urban spaces. At the same time, there is a shortage of specialists. 66% of healthcare provider shortage areas are actually in rural counties, and distance from facilities. Rural residents are about twice as far from a hospital as their urban counterparts. These same issues also confound the ability to address substance use disorder effectively in rural spaces. Rural spaces have higher incidences of substance use disorder. It starts at an earlier age, whether it is for alcohol or other drugs. It just is a more prevalent problem, often in some rural spaces than in urban areas as well. And those same issues that affect healthcare generally in rural areas, in terms of the spread out population, the lack of money, the lack of resources, the distance from facilities, affects effective treatment of substance use disorder as well. So again, it's lack of access to professionals, it's distance, and then again, in rural areas, there might be cultural conditions that affect the ability to treat substance use disorder effectively. Telehealth can answer a lot of these challenges. Telehealth enables better health outcomes, cost savings, access to experts, monitoring for chronic conditions. It encourages compliance. And in many of these instances, these are just based on the ability to facilitate patient-physician interaction more effectively without the need for a long drive to a hospital, without the need to be in a waiting room, without the need to make a choice. Do I need to take a half a day off of work to go visit the doctor? Or can I open up my laptop and spend 30 minutes with that physician interaction in the comfort of my own home, my office, my living room, rather than have to drive to the doctor, wait perhaps for a while in the waiting room before I finally get called in. NTCA Smart Rural Community did a report several years ago, and we took a look not only at the health outcomes that accrue from the deployment of telehealth in rural spaces, but the financial and the economic benefits as well. And these are categorized into 2 columns. One of them are avoided cost savings, and the other one is actual revenue generators. So on the avoided cost side, what we find is that travel expense savings were close to $6,000 per facility per year. Gasoline, wear and tear, and transportation costs, patients to get to the hospital, lost wages savings per facility were on the order of close to $3,500 per year. Hospital cost savings were more than $20,000 a year, again, because of early intervention, monitoring, and compliance improved with telehealth. In terms of actual economic benefits, again, these are actual positive impacts on the ledger. Pharmacy and a lab revenues increase in rural areas. Why? Because a patient is now at home in his or her home community conducting that interaction with the physician. Physician issues an order for pharmacy or lab work. That lab work is done locally rather than at the hospital, where the pharmacy may be 40 miles away, where the patient otherwise would have gone without telehealth. So again, this is just really a very broad introduction to the issues, and I look forward to the conversation this morning. Thank you.